we go. All right, you should be good to go.
All right. Very good. Thank you, Chantry. I'm
Yeah.
Toni DiChiacchio. I'm a nurse practitioner here at WVU Medicine in Morgantown with the addiction section of behavioral medicine and psychiatry. And I'm going to talk about the legislative session that just ended in April this year. Next slide. And particularly the impact that it has on us as treatment providers for patients with substance use disorder, and also some of the impact that it has on patients themselves. Next slide. So this was a tone, I would say, of this legislative session that ended in April. There were some pretty sizable introduced bills that had significant impact on the industry, and it caused a lot of stakeholder input and anxiety and contemplation of how we would continue if these bills became laws. But then at the end of the day, like nothing really changed because most of the laws that would have impacted delivery, at least, did not come to fruition. That doesn't mean that the issues that we'll talk about today won't return, and probably they will likely return, at least conceptually. So it's not only a good time to learn about what happened with the legislative session, what's changing in West Virginia, but what to consider and contemplate for future sessions, and perhaps engage with your legislators if there are areas you feel your insight would be beneficial for them. Next slide. So this legislative session and all, there's a lot of press about how it was like a relatively slow or unproductive session. There's several reasons for that, but if you're looking at absolute numbers, it is true that less than 10 out of the past 5 years, only this was the session that the least percentages of bills passed, and the absolute number of bills passed was the lowest. But as far as the bills that were introduced, it was the second highest in the past 5 years. So some of this was based on circumstances, and some of it potentially by design. If you look, I know it's too little to read, but if the on the bottom right corner where it says legislative midterm report, that was a commentary by Stephen Allen Adams, who's a Capitol reporter for Ogden News, and he was talking in that section about how Speaker Hanshaw, who's the House of Delegates leader, Speaker Hanshaw, had talked about prior to session that the focus was going to be on quality this session and not quantity. So some of this was by design. One of the things he did this session was change the committee process. Instead of when bills, we'll use House Health and Human Services Committee for an example. Instead of having a bill introduced and referred there and then them have debate and amendments and passage all on one day, he broke it into 3 days. So day one would be hearing day, and people, including anybody that wanted to, that's a citizen, could sign up and speak to the legislators in that committee about the bill that was being debated. So that was day one, and the legislators could also bring up witnesses and ask questions. Day two was amendment phase. Day three was passage phase, and then it would go on to the floor. So that what usually took like one day or one committee hearing, and now is broken down to three. And so a lot of this was by design, the less number of percentages of bills passed. Also, we had this was a post-election year, so we had a new legislature, completely new. Now, there were some incumbents that came back, but there were a lot of new delegates and senators. And in fact, on the Senate side, the prior president of the Senate had lost his primary race. So he obviously wasn't Senate president anymore. So we had a new Senate president who's Randy Smith. He's in the Preston Tucker County area. And so, and a lot of freshman legislators. So that slows down things a bit as you have new leadership in committees, you have a new foci of what your vision is and what you want to see in the session. So it makes sense that it was a little less productive than prior years. Next slide. The health committee, the bills passed through the health committee that ultimately crossed the finish line. It was a very slow year for health related bills as far as what ultimately passed. Of the 249 bills passed, only 34 were health related or went through, i.e., went through a health committee in either the Senate or the House. And that could be good or bad based on what you think of the bills that were introduced that impacted health. But pretty slow outcome year for policy changing in health. Next slide. So I asked AI to create an image of what policymakers could ideally do when crafting laws to address the substance use disorder in any state. And this was the image that it produced, kind of a balance between demand side policies, i.e. the demand for these substances. So patient access, treatment, expanding funding, et cetera. And then also on the supply side, which would be more law enforcement related and dealing with traffickers and the whole illicit economy is on depicted on the right side of supply. I will say this was an interesting session in that there was definitely some demand-based policies, i.e. treatment kind of based policies, but they were more on from the perspective of the legislature, focusing not on necessarily expanding access to treatment overall, but to kind of refine into the vision of what they think good treatment is for West Virginia. And then there were several legal kind of law enforcement bills passed this year. Next slide. So from 2016 to 2024, the House of Delegates had a health subcommittee that was on the treatment of and prevention of substance abuse. That's what it was called. But they didn't, with Speaker Hanshaw changing kind of the process for committee work, that wasn't back this year. But for the first time ever, the Senate side, the Senate chamber, did have a select committee on substance use disorder and health. So this was the inaugural year of that committee. The two leaders you see on in their pictures, chair was Brian Helton and vice chair was Scott Allen Fuller. Both of these are new senators, so their very first year in the Senate. Senator Helton is from Fayette County and he's a business person. Senator Fuller is from Wayne County. He has a history of military and law enforcement experience. And then the other committee members are in green on the right. Senator Deeds is from Greenbrier County and he has a background in law enforcement. Senator Weld is an attorney from the Northern Panhandle. I don't know if he's still doing this, but at one point he was a prosecutor, so clearly on the law enforcement side. So very heavily weighed on like the law enforcement side, where they could give insights on what it looks like in the front lines of dealing with substance use disorder from a law enforcement side. As far as like health representation, Senator Takubo is a DO. He's a pulmonologist and intensivist. And Senator Tarr is a physical therapist, and he's also a business owner of a number of businesses. So both have some healthcare experience, none specific to treatment of substance use disorder, however. Next slide. So this Senate Select Committee on SUD and Mental Health in total had 11 plus 8, 19 bills that came through their committee. And these bills I circled pending because they're still sitting in committee after the legislative is part-time here in West Virginia. So these are dead now. They can't move forward because the session is over. But these were the bills that were left in that committee when the session ended. And the little icons I have beside a few of those bills is for bills that passed, but in kind of a different form, a different bill number with slightly different language. But there was a bill that passed regarding involuntary hospitalization for patients with substance use disorder. And the little stars represent a bill that was passed. It ended up being called Lawrence Law. It was through a different bill number, however, and it increases penalties on certain fentanyl, basically, increases the penalties on the sale and trafficking of particularly fentanyl. And the little arrow there by Senate Bill 628, this is just to represent that we don't always need the legislature for changes to occur in West Virginia around anything, but even in particular, our treatment arena. That bill, and it had been introduced a couple years, the concept of it was for healthcare payers, insurance companies, not to prefer or discriminate against non-opioid medications for pain. So opioids are fairly cheap and most insurances cover them because they're not really costly. But there was a new medication that was FDA approved, I think in January, early this year, called Journavax. I believe I'm saying that correctly. It's a non-centrally acting pain medication for acute pain. It acts on calcium channel blockers peripherally. And so there was hearings on this during this session, like really to encourage that kind of medication be paid for. That bill didn't pass, nor did other bills that looked like it. However, during this time, early in the session, there was an emergency pharmaceutical and therapeutics committee meeting for Medicaid, which I just ironically serve on, that was called around this time at request of the executive. That committee really does clinical advisement in the context of costs of these medications to determine what will be on formulary for Medicaid. So the people in the health, like pharmacists, physicians, nurse practitioners, PAs, are on that to try to encourage the committee not just to focus on money, but to consider clinical consequences as well when they're deciding on what will be preferred on formulary for Medicaid. Anyway, we had this emergency meeting, and this whole Journavex thing was brought up, and that it did end up, the committee did vote to recommend it be on the preferred medication list for Medicaid patients. So that should be an option right now for your Medicaid patients to get paid for. The whole point is you don't always need the legislature to codify things to make changes. Next slide. So some of the bills that actually were heard through this committee, there were 8 bills that passed through the Senate Select Committee, and there was one about drug trafficking, and the Joel Archer Substance Abuse Intervention Act is about involuntary commitment for SUD. Again, these bills weren't specifically passed, but some lookalikes were. There was also a bill that nearly passed relating to testing for substance use disorder. That was Senate Bill 939. We'll look closer at that in a few minutes. Senate Bill 723 and 739. The legislature in the past several years has really tried to wrap their arms around inpatient, like detox residential treatment centers and recovery residences, and getting to the bottom of like what is the most effective, what should they kind of measure. They've tried a couple times, not successful yet. So there was a couple bills about that. Those didn't end up getting anywhere this session either. If you just click down, I think it will. There's a cut. So none of these in this form ended up passing. Click down one more time. But we're going to focus on 726 here for a bit because that would impact office-based MAP programs and opioid treatment programs in the state pretty significantly, and would have made us how we deliver care quite different if it had passed, particularly as introduced. Next slide, please. So as introduced, Senate Bill 726, the short title relating to MAT programs, really focused on this integrative care model. And so that was, there were 2 elements, integrative care, and the second was tapering off of MOUD. This is both for OTPs and OB-MAT clinics. And the bill required that OTPs and OB-MAT programs integrate basically what I would consider expanded primary care services on the site of their clinics. It also required internal audits of patient charts to determine if, to evaluate if tapering schedules were being followed, MOUD tapering schedules. And if that internal audit showed that 50% or more of patients were not on a recommended tapering schedule, it required director involvement. I wasn't really sure from the bill if that meant director of the program or director of OFLAC/OIG. It didn't really differentiate that. But anyway, like some kind of leadership involvement to start looking at those cases that weren't being tapered and to craft a plan over a 6-week period to apply a recommended tapering schedule. And then after 6 weeks, if a recommended tapering schedule wasn't implemented for the patient care plan, then those programs would be in violation and potentially be penalized. If you notice on the bottom right, the sponsors of that bill included, the chief sponsor was Senator Helton, who's also chair of this committee. So obviously something that he is important to him. One of the big problems here was like, what is a recommended tapering schedule? Like the manufacturers don't have recommended tapering schedules. Research doesn't indicate a recommended tapering schedule. The government, SAMHSA, CDC, they don't have a recommended tapering schedule. So there really isn't such a thing. So that was one of the big problems with the legislation as introduced. Next slide. As far as the integrative care concept in this bill, which was required to be, quote, on-site, which really there was not a great definition of on-site in the introduced version. included several things to be started this year in the fall, and by next year in the spring, other things. Some of these things we already do, and the OB/MAT rules require it. For example, offering screenings for HIV and hepatitis, talking about birth control. Those are already overdose prevention, supplies, and education. Those are already in rules that OB/MAT programs have to follow, as are behavioral health services, which you can see is in the lower list. But then some other things like screening for and treating chronic disease, doing vaccinations on site, advanced diagnostics, not exactly sure what that meant either. And then nutritional counseling, weight management, other health improvement strategies for health education and counseling, which that was not the limit of the list, were included on this vision of what integrative care should look like for patients getting treatment for substance use disorder. Really, on paper, it looks fantastic. I would love to go to a one-stop shop like that if I could, but I don't, it's a little more complicated than that in our healthcare system, which is very much specialized and a bit siloed, and also the whole billing billing and compliance area that necessitates certain credentialing requirements that it's just not that easy to bill for some of these services if you're in a certain kind of clinic. So it looks lovely on paper, would be a lot harder to implement that I think a lot of people understand unless they've been in the healthcare arena for a while. Next slide. So I encourage everybody, if you have time, you could even do this to go to sleep at night. The West Virginia Legislative webpage archives the Senate committee meetings. They do now too for the House, but it's only the audio for the House. The Senate has video and audio, and they've had this for a couple years. And there's a link embedded in this on the date that the 726 was heard, which was the 12th of March. It will really benefit you to hear what some of the concerns and questions that some of these senators ask and where they're coming from. You can clearly get a theme from the debate and inquiries and the hearings. So that's if you would pull that up, that's what the first screen would look like. There will be a little play button. You can select what bill you want to hear, just start it from the top. But I really encourage you to listen to this and others that I'm going to talk about in a few. Next slide. So when on the 12th of March, when they had that hearing that I just was pointing out on the previous slide for Senate Bill 726, they came up with a committee substitute. So that original version with the tapering and integrative care, they had crafted language before they started that committee to do this committee substitute. And the new language in this new bill was more defined what on-site meant. And on-site was required to be provided by a licensed healthcare provider under Chapter 30. That's like physicians, nurses, LPCs, social workers. Someone that had a license couldn't be like a case manager that was unlicensed, for example. It meant in person and on the premises of the OTP or OB/MAT treatment center. So, in your treatment space. And it also added that integrative services could not be done by referral, and they could not be done solely by telehealth. So really the expectation was we as OB or OTP providers had to have that full list of services available where we work and see patients in person. They also removed the taper language because, as we said before, there really isn't great recommended tapering language. Instead, putting in informed consent that had to be done quarterly by a licensed healthcare provider, talking about risk and benefits of continuing treatment, including continuing MOUD, and also doing an assessment and documenting that the patients were doing everything we can to allow the patients to meet their highest physical, mental, psychosocial well-being. And certainly embedded in this during the debate, you could clearly hear that meeting your highest physical, mental, psychosocial well-being includes being tapered off of MOUD. So that was still a concept that they were focused on, but not so overtly and explicitly in the language of the bill. And then thirdly, they put telehealth limitations in this committee substitute. So they required that the Office of Inspector General come up with standards on addiction treatment in telehealth, and that at a maximum of a third of a patient's care over the course of their treatment could be provided via tele. Which was really interesting because prior legislatures, since West Virginia has been Republican dominated since 2015, but as of the 2014 election, 2015 legislative session, but really heavier and heavier and heavier in the predominance of the Republican Party. And prior Republican legislatures, after COVID, really focused on continuing the telehealth access. And in fact, while they put up some guardrails in prior years' legislation and ultimate law about when telehealth was appropriate, they had carved out or given an exemption to behavioral health and substance use disorder treatment. So prior Republican dominated legislature had said, yes, we need to keep telehealth open access for those services for behavioral health and addiction treatment. But this particular legislature, or this at least this Senate Select Committee, felt that excess telehealth was a problem, and so they wanted to limit it to a third. Next slide. So this is the same kind of picture. This Jeff Johnson is the attorney for the Senate Finance Committee, because that's where the bill went. It did pass the Senate Select Committee for Substance Use Disorder and Mental Health on the 12th, and then was referred to the Senate Finance Committee, which it wasn't heard there until the 31st. And in that time frame, a lot of stakeholders, including some people that are involved here, really got involved in, sharing their perception of how workable that language would be. And that bill was heard on the 31st. And again, next slide, another committee substitute was crafted. And in this committee substitute, now it included entities and not just OB-MET centers. So in theory, if like a healthcare system has a OB-MET treatment place, other like sister sites that are owned by that same entity could be the site for which this integrated care was provided. It also removed the prohibition of the doing integrated services by referral. Or so remember that committee substitute said those integrated services could not be done by referral, nor solely telehealth. This bill removed that prohibition, changed the required start date to July of 2026 instead of this year. Next. Still required the quarterly assessment of highest level of well-being and informed consent on risk and benefits of buprenorphine or methadone. Next slide. This was the big one. For clinics that were OB-MET licensed or registered by OFLAC and prescribed just buprenorphine, so this would not be the methadone clinics, this would be for OB-MET programs, and had behavioral health services, which to be registered, you do have to provide behavioral health services, and adhere to ASAM guidelines. That whole big list of integrated services was no longer required. Quarterly assessments continued to be required. And for telehealth people receiving care, at least once every 6 months, they had to come on site. So that was a significant change in the prior derivation of the bill. Next slide. So it ended up passing Senate Finance, going to the floor. It passed unanimously, but not before it again was amended on the floor of the Senate, wherein they removed even that Q6 month in-person visit for telehealth delivery and changed it instead that patients delivered telehealth would deliver care via telehealth must have a referral every 3 months to a primary care provider. So it's quite different than the original bill. And that's generally how bills go. They start out in one way and look completely different at the end. But after all that, and really a lot of energy placed in getting that bill to a pragmatic position, it went to the House side and just didn't get any traction, and nothing happened there. So that bill did die. I'm sure concepts will return next year, though. Next slide. There's a novel bill, Senate Bill 109, that was again introduced from the Select Committee. Senator Tarr was the primary and only sponsor, and this goal was the goal of this was to create this like special revenue fund where money would be used to basically pay informants for information on drug traffickers that lead to an arrest. Already paid informants were excluded from this reward program. And then also to advertise the program in and out of the state, like put billboards on, like as you cross into West Virginia, like advertising, like we caught this trafficker and now he's in jail for 40 years or whatever, like just to deter drug trafficking into the state. And the money was going to be raised by charging a penny on the sale, on the purchase, excuse me, of Narcan kits, and opioid test strips. So at point of care, anybody that would buy Narcan would have to pay an extra penny, and then that would go into this fund. And there was a lot of debate about, well, should nonprofits and tax exempt organizations that really largely distribute, like purchase and distribute this, are they going to be having to pay that 1 cent tax, which ultimately the bill said no. And then the debate came down, well, would this even raise any money when you consider how much tax-exempt nonprofit entities buy these things for end users, for patients? And if this is something we want to do, maybe we should get it from the general revenue fund as, a funding source, and not from this sales or excise tax, which in theory could punish someone who's trying to protect themselves or their family by preventing, overdoses. So it didn't get any traction. It may come back next year, I'm not sure, but probably not in the same form as this sales tax of a penny. There have been bills introduced in the past to put a penny excise tax on opioid, like Percocet, Lortabs, any Schedule II opioids, but that never, and then use that money to go into treatment programs and education, prevention education, but that never passed either. Next slide. That was even actually Joe Manchin even federally had introduced a federal law like that. If you listen to any of these hearings, this is the one I would recommend you listen to first, because it really, really, really shows these senators' concerns about methadone clinics, and then also why they think integrated care is the way to go. This hearing was held on the 5th of March, even before the 726 bill. And basically what this bill said was there would be no opioid treatment programs in West Virginia. None. The 9 programs that we currently have would close down, and they'd have a 120-day administrative wrap-up. And that bill ultimately was debated and changed to kind of that integrated care model with a set date of having those services on site by July of 26. It was also amended. Currently, Marshall is doing a clinical trial of basically a methadone, an office-based methadone program instead of like dispensing. And it's similar to how you would do buprenorphine. The legislature, during a special session last year, did a carve out because there's a moratorium on methadone clinics, and they did a carve out to allow Marshall to participate in that clinical trial. So this bill was amended to make sure that Marshall could continue that trial, and then allowed a little extra time for wrap up if those OTPs would not do this integrative care model. And then there were pretty hefty penalties. A lot of times bills will pass in West Virginia that will basically be recommendations because there's no violation or penalties associated. But this did have a $2,500 per day violation for OTPs that continued after the deadline. It did pass this committee. It went to Senate Finance, did not get on their committee, so it also died. Next slide. But there really is concern by these legislators about methadone, deep concern. So if if you have a relationship with your senator or delegates, or even if you don't, maybe making a relationship with them to better understand what their specific concerns are, and how, as a group, as a team, we can make things better. Senate Bill 939, this did almost cross the final finish line. It was codifying drug testing requirements. Currently, OBMAT rules, we already have very specific rules in law and rule, and in statute and rule. But this kind of lessened them a little bit via statute. It still makes me, it's just so interesting to me that you would put this in statute. But so upon admission to an OBMAT program, a patient would have an observed quantitative drug test that was comprehensive, and then every 2 weeks for the following 6 weeks, an observed quant. And then from 6 weeks to 1 year, an observed quant or qualitative test every 45 days. And then after a year, at least every 6 months, a quant or a qualitative test. So that passed the Senate just as is, written there, went over to the House. The House did an amendment a little bit, saying that direct observation was not required, but if the clinician thought it was appropriate, then it should be observed on admission, that the Q 2 weeks for the first 6 weeks was at a minimum. That clinically you could have more, and they changed the quantitative to a qualitative test for those first 6 weeks. And then someone had amended it to offer infectious disease testing, which there is already in rule for OB-MET program, but it was amended anyway. So that's what the House did, and the House had to send it back over to the Senate because now the Senate has to concur on the changed language. And the Senate attempted to amend it again to have quantitative or qualitative testing in the first 6 weeks, and the integrative care language resurrected from the final version of 726 and was placed in this bill. So clearly, this integrative model is very important to especially the Senate side. So it probably will come back again. Anyway, it was amended to include that, went back to the House, but it ran out of time because by midnight on the last day of session, you only have till midnight, at midnight last day, if you don't pass something, it's dead. So this bill too died. Next slide. So some new laws that did actually pass, and we'll go through this quickly because I know we have a case. Lauren's Law, Senate Bill 196. This is Governor Morrissey. He came up here to Morgantown to sign this bill at Lauren's wish. Lauren, I believe her last name was Cole. I did not have the honor of knowing Lauren, but apparently was a lovely woman that herself had a history of substance use disorder and was in recovery, but ultimately had a relapse. And in her substance that she purchased, there was fentanyl, and she died of an overdose. Her parents have been very assertive and honoring her, and that's why they created Lauren's Wish up here, which is kind of a transient place where individuals after like residential or detox, but before they find a sober living residence, can park and live for a short period of time. Likewise, people that there's no open beds for detox but have been cleared by the ER can stay while they're waiting for an open bed in Lauren's honor. And so this bill really focused heavily on mandatory minimum sentences and creating more serious felonies. So basically heavier punishment for trafficking or selling drugs that contain fentanyl. Next slide. And this is just an overview. The fentanyl containing substances were already clearly illegal in the state, but this kind of shifted the onus on if someone knows intentionally they were doing it. And after Lauren's Law, they don't necessarily have to know that it was in there. If it causes someone's death, they're still going to be punished as if they did know that it was in there. There was no mandatory sentencing enhancements in prior law before this passed. Now there is mandatory sentencing that gives judges a lot less room to negotiate. Next slide. And so this is just a comparison of the sentencing that will happen before and after the law goes into place. 1 to 15 now will be a 10 to 40 mandatory, no parole, probation. Some of these cases, home confinement or parole will not be an option at all for judges. There's a new transporting controlled substances into West Virginia was always illegal, but now it is specifically addressing fentanyl. And if someone brings it into the state, they'll have a 10 to 20 if they're caught, mandatory minimum. Possession with intent also has enhanced penalties if fentanyl is involved. And really, in conspiracy to traffic, if it will be punished just as heavily as the actual trafficking individual that was arrested with the substance. So very, very heavily focused on fentanyl particularly, and enhancing crime with no judge discretion. This will go into effect July 11th of this year. So the Lauren's Law is not in effect yet, but in July we will see that law go into place. Next slide. And then this Joel Usher Substance Abuse Intervention Act, House Bill 2347. There was a lot of news in the press as if substance use disorder wasn't already included in the involuntary commitment kind of criteria, which it has been. In addition to serious mental illness, substance use disorder and involuntary commitment has been a possibility since at least 2020. I don't know how often it's used, but this bill was kind of to enhance and tighten up for theoretically more utilization of it in West Virginia. Next slide. So the bill as passed, there were several different bills that kind of addressed this, but and I actually believe I believe Jeremy Usted testified at one of them at a Senate Health Committee, but it allows for expanded use of video for probable cause exams. It does define an outpatient treatment pathway that was codified for people that are suffering from substance use disorder and have lost control and are harm to themselves or others. There's mandatory release criteria and time limits as not to take people's individual liberties. There's new professionals that are allowed to evaluate. Specifically, there's several, but um, uh, NPs and PAs used to be required to have a psych mental health certification. Now that's been brought into a list of just NPs or PAs in general. Obviously, you would want some experience in substance use disorder to be able to adequately assess somebody that should lose their freedom, but freedom for treatment. But that list was broadened, and then there's supposed to be continuous coverage regionally for these hearings. And then a couple other ones, and then I'll be finished. This House Bill 2402, effective July 11th. Prior to this, minors had confidentiality carve out in state law in regard to specific kind of medical records, STD testing, contraception, addiction treatment, substance use disorder treatment, and prenatal care. That has now been eliminated in West Virginia. So parents now have the right to those minors' records for whatever the cause, including those that were previously carved out. There are a few exceptions if someone is emancipated or a high school graduate at 17, or if there's a court order for confidentiality because of risk to the minor. Those would be exceptions where the parents would not have access to those records. But other than that, parents now have, as of July, they will have records to everything related to their minor children. And then House Bill 2441 made people unemployment ineligible if they failed a drug test and they're in an inherently safety risk kind of position. Before, people wouldn't be eligible to receive unemployment if they refused to take a drug test, but there wasn't an explicit comment about failing that drug test. Now, if they refuse and or fail a drug or alcohol test and they are in a high-risk safety position, then, like truck drivers or nurses, doctors, healthcare providers, then they would be ineligible to receive unemployment compensation.
Question, Tony. Doesn't that mean that nurses, truck drivers, police officers, no one's allowed to drink alcohol ever again then?
So that
I
they
said,
never allowed to drink alcohol again?
yeah, I think
Well, I
so.
mean, that is an
Just
interesting concept because at least the metabolites last a little while. I mean, like usually
Yeah.
it's based on reasonable cause that people are tested, but yeah, I don't know how they're going to apply that. This is just a site that shows the West Virginia legislature. If you're interested in any of those bill numbers that we covered, to actually look at the actual full language of the bill, you can plug the number in there. Make sure it says 2025 regular session and not 2023. And you can read the full bill, like that Joel Archer involuntary commit. That's a 25-page bill. There's a lot of details in that. And obviously I can't get into all of the details, but those are all available. Next slide. And just want to really encourage. I do believe the concept of taper, potentially, certainly the concept of integrative primary care embedded in treatment will come back. Those drug testing things may come back. That wasn't a major bill, but that almost passed. And oftentimes things that almost passed are just automatically reintroduced and run through really quickly at the beginning of the session. So, as we looked at the beginning, that scale of treatment, demand, law enforcement, supply, it's really important to have a good balance, and that there's not a lot of addiction treatment specialists, or there are some healthcare people, but not a lot of people that have the experience that everybody on this call has. And so if you're so motivated, making friends with your legislators, senators, or senators particularly, just to share and invite them to conversations in a pleasant way. We all want the same thing at the end of the day, but just to share your experiences, offer yourself as a resource if they have any questions or have concerns, and just kind of, develop that relationship, because some of these concepts I'm sure are going to be back. Any questions?